Good morning, everyone. I'd like to thank organizers for giving me this opportunity, and I'd like to thank Ashish Bindra madam for guiding me for this topic. So I'll be discussing on refractory and super-refractory status epilepticus and its implications for neuroanesthesiologists. The outline of my discussion will be defining refractory and super-refractory status epilepticus. We'll discuss the pathophysiology, rationale for the aggressive treatment, the prognosis and the treatment options, and the role of neuroanesthesiologist as well as intensivist, and then summarize. Status epilepticus, as had been defined by International League Against Epilepsy in 2015 as a condition which results either from the failure of the mechanism responsible for the seizure termination or from the initiation of the mechanism which leads to abnormally prolonged seizures after the point T1. So if a seizure, that is a tonic-clonic seizure, if it is continuous after a time frame of T1, that is point T1 for 5 minutes, there is a high propensity that this seizure will continue for a longer time. And if it continues after the time T2, there may be chances of long-term consequences, which includes neuronal death, neuronal injury, as well as the alteration in neuronal networks. The conventional stages of convulsive status epilepticus has been divided because with the time frame from the onset of the status epilepticus. The first 5 to 10 minutes from the onset is called as impending status epilepticus. 10 to 30 minutes after the onset is called as established status epilepticus. 30 to 60 minutes after the onset is called as refractory, and if the seizures continue for more than 24 hours, it is called as super refractory status epilepticus. What is refractory status epilepticus? If a convulsive seizure lasts longer than 60 minutes, which may be continuous or intermittent without the return to the baseline mental status, or if an acute convulsive seizure that fails to respond to 2 anti-seizure medications, one of them being non-benzodiazepine anti-seizure medication, is called as refractory. The relative prevalence is almost 10 to 30%. When a seizure continues or recurs 24 hours or more after the onset of anesthetic therapy, or if it recurs on the reduction or withdrawal of anesthesia, is called as super refractory status epilepticus, and almost 1/5 of the patients with refractory status epilepticus go on to have super refractory status epilepticus. Coming to the pathophysiology, the local hypersynchronization of excitatory and recurrent inhibitory neuronal networks, they diffuse to the rest of the brain and they generate a spontaneous seizure. So these paroxysmal hypersynchronous electrical discharges, they result from an imbalance between the too much of activation and too little inhibition. So we should understand the concept of receptor trafficking, where they have found that there is an internalization of the GABA A receptors, which causes a reduction in the potency of benzodiazepines as a treatment. There is activation of NMDA receptors, which leads to glutamate induced excitotoxicity, and there is upregulation of P-glycoproteins, which results in rapid export of phenobarbital and phenytoin molecules. So thus, in turn, it is an imbalance between the proconvulsant and inhibitory peptides, which leads to status epilepticus, and if it is not treated, definitely it becomes refractory. So what is the rationale for aggressive therapy in such patients? Basically, it is because of the complications and the dreaded complications. The most important complication is cerebral damage, the hypoxic insults which result from the status epilepticus because of the excitotoxicity. There are cardiorespiratory and autonomic complications which are secondary to the catecholamine surge during the status epilepticus. Dyselectromyelias, rhabdomyolysis, acute kidney injury, disseminated intravascular coagulation are the other metabolic and systemic complications of status epilepticus. One of the studies conducted by Tristan et al. In 2009, they have found that there is a better outcome when in the younger patients who have absence of any medical comorbidities, absence of structural brain regions, and who have a seizure duration of less than 10 hours, that is short duration, as opposed to there has been a poor outcome which has been found in older patients who have an underlying etiology and a longer seizure duration. So when you come to the prognosis, the overall mortality with status epilepticus is almost 25%, with almost 48% of mortality with refractory status epilepticus, even with aggressive therapy. In case of super refractory, the mortality is almost 30 to 50%, specifically in the cases of new onset refractory status epilepticus, as we call NORS. So 1/4 of these patients with all super refractory status epilepticus, they have good outcome, but most of them have significant residual impairment. So the aim of our treatment is primary aim is to control the seizure and prevent the excitotoxicity. Secondary aim is neuroprotection, and third aim is to avoid and treat the systemic complications which are related to prolonged unconsciousness and anesthesia drugs used for the treatment. So what is the evidence for the use of drugs and other modalities for the treatment of refractory and super refractory status epilepticus? There is a lot of research papers available, but the maximum evidence is available with midazolam, phenobarbital, propofol. So when we encounter a case of refractory status epilepticus in our neurocritical care ICU or in emergency, the first basic thing is stabilizing the patients. We start with ABC, airway breathing and circulation. Intubation should be done as early as possible to secure oxygenation and ventilation. Finger blood glucose should be examination should be done to diagnose hypoglycemia and treat accordingly. A good peripheral IV line should be secured to start emergent initial anti-seizure medication therapy within 5 minutes. Start for the fluid resuscitation. Nutrient resuscitation like thiamine should be transfused along with dextrose in cases of alcohol withdrawal, and vasopressor support should be initiated to support cerebral perfusion pressure. So when by the time we stabilize the patient, we should also look for the cause. What is the cause of this status epilepticus? So the most common causes being head trauma, stroke, CNS infections, metabolic disturbances, and non-compliance with anti-seizure medications. The other few less common causes are withdrawal of the drugs, drug toxicity, hypoxia, cardiac arrest, hypertensive encephalopathy, and some autoimmune causes. Some chronic causes we should be in our mind is CNS tumors, chronic ethanol abuse, and any pre-existing epilepsy patients who may have breakthrough seizures or discontinuation of anti-seizure medications. Specifically in children, we should know that prolonged febrile seizures are the most common cause of status epilepticus, and CNS infections and inborn errors of metabolism should be in our mind. So what are the treatment options? With the status epilepticus, all the treatment protocols start with benzodiazepines as the first drug of choice, plus the second line anti-seizure medications is started like phenytoin, valproate, levetiracetam, bivaracetam, and lacosamide. For refractory status epilepticus, we have IV anesthetist, midazolam, propofol, thiopentone, ketamine. For super refractory status epilepticus, there are only few options like inhalation agents, some miscellaneous drugs, and surgery, which we'll be discussing in few slides. So once we have found, or if we know which is the etiology for status epilepticus, a etiology specific treatment needs to be initiated as early as possible. For example, if there are metabolic disturbances that needs to be treated. If we are suspecting inborn errors of metabolism in children, we should start pyridoxine as early and avoid valproic acid. If infections are suspected, it should be treated accordingly with antibacterials and antivirals. If autoimmune encephalitis is suspected, immunotherapy should be started early. So when we implement aggressive therapy for refractory status epilepticus, there is a universal agreement that general anesthesia is the backbone of the therapy. And however, there is no agreement on the optimal choice of which anesthetic drug needs to be used, but there are the three conventional choices: thiopentone, propofol, and midazolam. What is the role of neuroanesthesiologist in intensive studies? Definitely in neurocritical care, airway protection, maintaining the hemodynamics, treat the refractory status with IV anesthetic agents, preventing the complications related to IV agents, and most importantly, weaning from the anesthesia drugs. In periphery, we may be involved from sedation or giving anesthesia for such patients whose seizures have been treated, and definitely in operation theater for the disconnection or resective surgeries, which are the last resort surgeries for the treatment. Coming to the drugs, midazolam, one of the only drugs which is only benzodiazepine which is suitable for the prolonged infusion, acts by enhancing the GABA receptor. Advantages being faster onset, strong anti-epileptic action, relatively short heart life, and allowing for the faster titration. The adverse drugs effects have been used. The active metabolite is excreted renally. That's why the prolonged effect may be seen in renal dysfunction. Cardiorespiratory depression is common. Most importantly, tachyphylaxis, seizure recurrence after the loading dose, and seizure relapse and withdrawal has been seen with midazolam in many of the research papers. Propofol acts by modulation of GABA receptor and inhibition of NMDA receptor, the advantage being very rapid onset and recovery after prolonged infusion, more control on the level and depth of the anesthesia, no serious drug-to-drug interaction, and definitely decreases cerebral oxygen utilization and decreases the ICP. The few disadvantages: pain and hypotension, though it is less than barbiturate and midazolam. Propofol infusion syndrome is an important complication which we should know, and also there is a risk of misinterpreting the drug-induced involuntary movements with GABA, with propofol, which should be in our mind when we are treating this. A short word on propofol infusion syndrome: rare but potential lethal toxic effect on mitochondria and cellular metabolic function. It's a dose and duration related. There is a high mortality and morbidity associated with rise in creatinine kinase levels, rhabdomyolysis, metabolic acidosis, ECG changes, refractory shock, or all the clinical manifestations. It was first reported in younger children. That's why better avoided. Barbiturates, thiopentone and phenobarbiturate act by enhancing the action of GABA receptor. The advantages being the strong anti-epileptic action, lowering the body temperature, theoretically neuroprotective drugs, and relative safety in longer experience of its use. However, the disadvantages being the longer T-half, hypotension, and cardiorespiratory depression is profound and usually needs vasopressor therapy, dynamic ileus, bowel perforation, pancreatic hepatic dysfunction, propylene glycol toxicity, and high infection rates are associated with the use of barbiturates. That's why we always keep a high threshold for using this drug. Ketamine, in its last 10 years, has been widely used and started being used as a treatment for refractory and super refractory status epilepticus. Being an NMDA antagonist, it has also advantages over the conventional anesthetics because of the no cardiac depression and potentially being neuroprotective. However, there is a theoretical risk of neurotoxic effects when it is used for prolonged periods, and the safety has not been tested. There is possibility of late development of cerebral atrophy, probably the excitotoxic effects of ketamine. And there has been definitely one of the disadvantages of raised IC with ketamine. However, the recent literature does not support this adverse effect. Inhalation agents. Now, it is one of the potential last resort for the treatment. The advantages being they're easily transported to CNS, that's why immediate seizure control. They're easily titrated to burst suppression and have a cerebral protective effect. Isoflurane and desflurane, there are many case reports and very, very few case studies for the use of inhalation agents. Desflurane requires higher MAC to achieve burst suppression, and sevoflurane being pro-epileptogenic, that's why it is definitely avoided. What are the disadvantages? When used for the longer time, inorganic fluoride levels may be higher in patients, probably the effects we don't know. Cardiovascular suppression, definitely yes, calcium-mediated myocardial depression is there with higher MACs. Isoflurane has been implicated in neurotoxicity and apoptosis-induced neuronal cell death. There definitely are the logistical issues of delivery of these inhalation agents in neurocritical care units. Long-term effect of these drugs, most of the studies are not available, and few of the case reports there have been other complications which has been reported like atelectasis, infections, paralytic ileus, and DVT. So how we select the drugs? The several questions arises about which drugs should be selected, for how long it should be used, how deeply we need to suppress the clinical seizures, and most importantly, how to taper and discontinue two drugs, assuming that they have controlled the status and now without the patient relapsing back into status epilepticus. This is one of the treatment protocols which has been found to be used by the Oxford hospitals in NHS Foundation. So once the refractory status epilepticus is diagnosed, they either use one of the two drugs, propofol or midazolam. So midazolam bolus doses followed by the continuous infusion, it is started to achieve ictal discharge suppressions on EEG. Once it is achieved, the midazolam infusion is continued for 24 hours seizure-free duration. If the propofol is used, the burst suppression, if it is achieved after the bolus dose followed by the infusion regime, and if there are no breakthrough seizures, they continue the propofol at least 24 hours seizure-free duration. When both the drugs have been used and maximum doses have been reached, the third drug is added, that is thiopentone sodium. Thiopentone sodium is also titrated after bolus doses to achieve burst suppression. And when the maximum dose of thiopentone has been reached, a fourth drug is added in this protocol, ketamine, to achieve the target. If all the four drugs don't work, then finally inhalation agents, surgery, or other miscellaneous therapies have started. So what I mean to say is, what is the endpoint of our treatment? The European guidelines suggest EEG burst suppression as the endpoint for propofol, thiopentone, and seizure suppression for midazolam. For how much duration? For at least 24 hours after the seizures have been stopped, and it should be maintained for the minimum period irrespective of which anesthesia drug is used. What are the other modalities? Neurosurgery. When there is a definite radiological evidence or electrophysiological evidence of focal onset of seizure, definitely the last resort treatment is neurosurgery in super-refractory status epilepticus. There have been studies on as early as use of 8 days following onset of status epilepticus, but most of them usually wait for 2 weeks for a failed medical therapy. Resection surgeries and disconnection surgeries are available to treat it. Magnesium, definitely the drug of choice in eclampsia, but it has been off-label use in refractory and super-refractory status epilepticus because there are no randomized controlled trials to support that. Mechanism of action is because in the NMDA receptor antagonist, it acts as a cerebrovasodilator. The therapeutic range from 30 to 60 microgram per ml is required to achieve anti-seizure effects. The advantages being only few drug interactions. Disadvantages are because of the magnesium toxicity. Pyridoxine. Now, this is one of the important drugs in inherited metabolic epilepsy, that is the pyridoxine responsive and pyridoxine dependent epilepsies, which is considered in neonate children less than 3 years of age, which present with refractory status epilepticus without any identifiable lesion on imaging. And it is recommended that to use this drug routinely in all the cases of super refractory status epilepticus in young children, because definitely there are no side effects. Steroids and immunotherapy with IV steroids, intramuscular ACTH, and IV immunoglobulin have been recently used in few of the epilepsy syndromes without any clear guidance, because there has been research that they have found that there are antibodies which are directed against the neural elements like NMDA receptors of GABA B receptor, and the role of inflammation in the epilepsy. Immunotherapy and steroids are helpful in few conditions like autoimmune encephalitis, NORS, and febrile infection-related epileptic seizures. Ketogenic diet. Now, this treatment has been preferred in childhood epilepsy after multiple drugs have failed, and in many of the refractory epilepsy syndromes. Usually, it is easy to administer through a gastrostomy tube or a parenteral feeding, and it is initiated after 24 hours of fasting. What is the postulated how it helps? Probably by potentiation of inhibitory neurotransmission, augmented of neuronal function through cellular level, hyperpolarization of the neurons through potassium channels, and chronic ketosis is postulated to stabilize and reduce the synaptic hyperexcitability. Thereby, it increases the seizure threshold. What are the contraindications? Congenital enzyme deficiencies, which are related to lipid metabolism. If they are present, definitely it's absolute contraindication with porphyria. If concomitant use of propofol, definitely there is a chances of high triglyceridemia. That's why it is related to contraindication. The complications are mostly gastrointestinal, like abdominal pain, emesis, constipation, and pancreatitis. Some cardiac and few metabolic, like hypertriglyceridemia and hypercholesterolemia, are other complications. Hypothermia. Now, hypothermia exerts its anti-epileptic action, and it has a neuroprotective role by reducing the brain oxygen utilization, ATP consumption, decreasing the glutamatergic drive, free radical production, and other oxidative stress. What are the risks? Acid-base disturbances, disseminated intravascular coagulation disorders, thrombosis. So how it is done? It is induced by endovascular cooling, and usually a mild hypothermia of 30 to 35 degrees Celsius is started for 24 to 48 hours. If the seizures are treated, it is continued for 20 to 48 hours. Barbiturate anesthetics are avoided with hypothermia. Patient needs to be monitored for coagulation parameters, acid-base, basically the arterial blood gases needs to be monitored. And we being the anesthetist, we should know that the clearance of the anesthetics and anti-epileptic drugs are usually reduced with hypothermia. What are the other palliative therapies? Vagal nerve stimulation, deep brain stimulation, and transcranial magnetic stimulation. There is a dismal results in epilepsy and not much data in support of transcranial magnetic stimulation. Vagal nerve stimulation, there are a few case reports on the use of vagal nerve stimulation in treatment of status epilepticus. However, the other additional therapies usually complicates the assessment whether it is the effect of vagus nerve stimulation or other therapies. And in one of the reviews conducted by Ziller et al. In 2015, they couldn't recommend the use of vagal nerve stimulation for refractory status epilepticus. Deep brain stimulation, there has been animal studies for stimulation of anterior thalamic nuclei for the treatment of status. However, there is no much published data to support the same. Electroconvulsive therapy, now it has been first used in 1930. However, the anti-epileptic effects are because of the increase in presynaptic GABA and prolongation of the refractory period of seizure post-ECT. However, the anesthetic should be withdrawn and anticonvulsant drug should be completely withdrawn before the start of electroconvulsive therapy. There has been case reports of successful use of electroconvulsive therapy in cases of febrile infection-related epilepsy syndromes. CSF drainage. Now, it is unclear how it helps, but probably because of the removal of inflammatory and other noxious substances in the CSF may help in refractory status epilepticus, and probably it may also help in intrathecal administration of anti-epileptic drugs, but there are only few reports or probably just a theoretical way to support this. To summarize, we can start with midazolam infusion followed by propofol and ketamine. EEG endpoints are burst suppression and suppress ictal discharges for the different drugs. Propofol and ketamine is usually added to reduce the tachyphylaxis seen most commonly with midazolam. We avoid propofol in young children. We check for metabolic acidosis, creatinine kinase level, triglyceride levels, and ECG changes when the patient is on propofol infusion. We keep a higher threshold for the use of phenobarbital, as I have explained about the disadvantages, and specifically look for hypotension, immunosuppression, and bowel ischemia in these patients. To summarize, this is the protocol which we use in our neurocritical care unit in the Department of Neurology in our hospital, in our institute. Thank you.